My name is Paul Bittinger. I'm the medical director for emergency preparedness at Massachusetts General Hospital and an emergency physician. So emergency preparedness is preparing entities or organizations for emergencies. It's very similar to what FEMA does for the country or what state emergency managers do for their state. It's making sure that all the systems and plans are in place before a disaster happens and make sure that they're tested and practiced regularly. We received 31 patients from the bombing. We admitted 12. The admission numbers are a little hard to come by. We think there were about 260 total patients, and somewhere probably north of 50 patients were admitted across the system. So Tent A is the tent at one of the major medical tents at the finish line, staffed by paramedics, nurses, physicians, others. And they take care of certainly some minor injuries and some major injuries as well. People have had heart attacks there previously, some more severe respiratory illness. But at the time of the bombing, thankfully, relatively few sick patients. And as soon as they heard the first explosions, what they did is they transformed into an emergent care area where they could stem life-threatening bleeding and quickly triage and transport patients to the area hospitals. So it's actually pretty interesting. Tourniquets used to be a very basic part of medical care for centuries, but in the later part of the 20th century, early part of this century, they fell out of favor. The thought was they caused more tissue damage to extremities than they helped. But from Iraq and Afghanistan, those conflicts, it was quickly realized that from improvised explosive devices, people were dying without the use of tourniquets, and the military made some rapid adjustments to provide tourniquets to every soldier and every medical provider in the field. They published those lessons, and our own EMS system here in Boston started using them. My hospital as well, Mass General, has started using tourniquets in the emergency department for the rare circumstance where someone comes in with a severe extremity injury and is bleeding out. We actually stock the same tourniquets in our emergency department that the military gives to their soldiers. In tent A, at the end of the finish line, certainly those types of tourniquets, the military tourniquets, were used by EMS responders, but also some responders, some volunteers, and others who happened to be there made up what they could. They used belts, they used other pieces of fabric, and that absolutely saved lives. I think one of the most important things is understanding what the right transfusion strategies are. Again, in the battlefield, unfortunately, there are a lot of lessons learned about massive hemorrhage, and we saw a lot of patients with massive hemorrhage after the bombings here. Knowing to avoid IV fluids, which dilute out oxygen carrying capability, which can dilute clotting capability, that's very important. And knowing to go with aggressive strategies with not just transfusion of packed red blood cells, but also fresh frozen plasma, clotting factors, platelets was really important and an integral part of the response here. There are a couple things. The first is to review the literature, review the experiences of people who've been through these types of events and make sure you plan for how they really unfold. When you look at the London subway bombings, the Madrid train bombings, others, you learn very quickly that you have very, very little time to prepare, that patients can arrive within seconds or minutes. And so planning to have a half hour, an hour to clear out rooms to get your capacity in line is just really not realistic. So we have plans to empty out the emergency department as quickly as possible. My own emergency department had more than 90 patients in it for a 49-bed emergency department when we first heard of the bombings. And so a lot of our plans have centered around rapidly creating capability and capacity. We sent a lot of the people who were in the emergency department up to the floors without the time for nurses and physicians to call report because we knew we didn't have that kind of time. And amazingly, we created more than 30 beds within less than 20 minutes. Our first victim arrived 9 minutes after we were first notified of the bombings, and it underscores the importance of planning to respond rapidly. We do have trauma resuscitation bays that are available to us for normal trauma. We have 3 of those. In our acute area, which is our most acutely ill area of the emergency department, we have a total of 20 places we can care for patients. But we certainly needed more than just the 3 major trauma bays to care for the 6 people that were most critical that arrived in very, very short succession. So what we do is we really make sure we can care for a trauma victim in any of those bays and make sure that we have the providers that can provide the care. So So we divided ourselves up into treatment teams with emergency physicians, surgeons, nurses, and tried to put one provider team per room so that as each patient came in, they were able to get a full dedicated resuscitation. A little bit of a hybrid. We never call ourselves lucky in something as terrible as this event, but I think we were fortunate that it happened essentially at change of shift, about 3 o'clock. And so we had the day shift that would have normally been going home and the evening shift that had just arrived. And so we had twice the number of providers in the ED that we normally would have in terms of emergency physicians and nurses. Our trauma surgery program is quite robust, and we had a number of trauma surgeons in hospital. We had 4 that were able to come down quite quickly. We did end up calling on other resources. We pulled down some surgical residents that were on other services. We had some other surgical specialists that came down, thoracic surgeons and others. But really it was remarkable that we had good amount of resources with both the emergency physicians and the trauma surgeons that were available to respond. So the most life-threatening injuries absolutely were lower extremities. So because, as has been reported in the press, the devices were at ground level, what we saw was consistent with that, which is lower extremity, partial amputations, near complete amputations, a lot of soft tissue injury, and certainly the soft tissue injury was not only limited to the lower extremities because of the shrapnel that was there, but that's where it was mostly concentrated. And then we also saw burn injuries, thermal injuries as well. We were really fortunate with ICU capacity as well. As soon as we heard of the bombings, we actually transferred a number of ICU patients to the floors as well, and were able to create 6 ICU beds immediately, and in total created more than 10. That's very hard for us, even as large as we are. We have more than 100 critical care beds in our hospital. But what we did is called in extra providers, opened up extra capacity. And so thankfully, by the time the patients came out of the operating room and by the time they were ready to leave the emergency department, we had sufficient ICU and floor capability. I'm sure there are things that we can do better. We're actually really trying to look with a critical eye at all of our response data right now. I think, though we had wonderful resources there, we can probably organize ourselves even better than we do. I think one of the most important things that we did very well during this response, or before this response really, was exercise and test our plans, and we're going to keep doing that. But there are portions of the hospital that we haven't yet gotten to participate in exercises like this, and thankfully I think people are very interested in participating in exercises, so we'll be expanding our preparedness exercise programs even more than we already have.